All right. Good evening, everyone. Welcome to the Myasthenia Gravis Association's virtual monthly meetup. We're so glad that you're here. If you are new here, please be sure to check out our website, www.mgassociation.org, for additional opportunities for connecting, as well as how to request a new patient packet. I'm Hallie Walker, and with me this evening is Allison Foss. Tonight is our last virtual monthly meetup for 2025. We are working on some great programming for 2026, and we'll resume our virtual monthly meetups on January 26th at 6:30 p.m. This evening, we are excited to welcome Dr. Gil Wolfe from the University of Buffalo to discuss with us the very important topic of, is it MG or is it aging? Please feel free to put your questions in the Q&A or the chat, and we will monitor them. Dr. Wolfe, feel free to take it away.
Okay, thanks so much, Allison and Hallie, for inviting me. I've spoken to this organization before. I'm based in Buffalo. Before that, I was somewhat closer to you guys. I was at UT Southwestern in Dallas, and I worked under Dr. Barron, who I think many of you have heard from or even have met in person before. I've known Allison for a few years as well, not as long as I've known Dr. Barron, but I've always had a great relationship with the Kansas City, both Missouri and Kansas side. There's been several links to Texas with the excellent group there, and I know the organization is expanding into Missouri, into Columbia, Missouri, where Dr. Barron is the dean. He's number 2 in charge of that whole university system. So it's great to be part of the talk today. And I don't have too many slides, and I think I'll take a break, maybe 2/3 or 3/4 through the slides, and see if there's any questions at that point, and then we'll have plenty of time for questions at the end. But the topic I was asked to talk about is it aging or is it MG? If you can't see the title there because of all the Zoom stuff, but that's what we're going to talk about. And I assembled a few slides about that. By the way, the pictures there are Buffalo in the bottom right, and that's Lake Erie. Buffalo is right on Lake Erie. We are a border town. Canada is just across the Niagara River from Buffalo. In fact, I can see Canada from my a little sliver of Canada from my living room window because I look out over Lake Erie. And that's the medical school at the bottom, right as they were finishing construction of our new medical school building, which is orange there, and the hospitals are off to the left. That includes a children's hospital, adult hospital, and to the back and to the right of that reddish medical school building is the oldest cancer institute in the United States. Buffalo has a lot of the oldest things. It's an old city. That's Roswell Park Comprehensive Cancer Center, which is NIH recognized. It is the oldest cancer institute in the United States. A lot of people don't know that. Named after a cancer surgeon, Roswell Park, who almost operated on McKinley and may have saved his life, but President McKinley died here after he was shot. Anyway, here are my disclosures. Over the last 24 months, yes, I'm involved with research. I'm a consultant for some of these companies that thankfully are interested in our disease, in myasthenia gravis, and you can see some of these direct research funding we get down at the bottom. Okay, so this is how I'm going to start. And just to let you know, we do pretty well with MG. Not that there's room for, not that there's not room for improvement. We want to improve things, but this is a disease in the context of all neuromuscular disease that's a fairly happy story, to be honest. There's so many challenges in neuromuscular disease that we have still to this day. ALS is a huge one, for instance. But what I want to point out, this is outcomes, and this is without the new targeted therapies. This is using conventional therapy in Austria. It was about 200 patients. They wrote this up, 5 or 6 years ago. What I want to point out is the late onset myasthenics in the dark blue are at the top of this graph. What does that graph mean? It means that those patients, over that period of time, they had to hit minimal manifestation status. If you don't know what that is, that means that you can basically do what you want to at home, at work if you're still working, and so forth. Maybe you have a little bit of weakness on exam, but it's really not interfering with your function. That's a good outcome. That's actually the desired outcome as international guidelines stand right now. Now, what they did here is they didn't only allow it at one time point. To get on this graph into those curves, you had to have it for at least a year. So they call that sustained minimal manifestation status, as you can see there, at least 12 months. And the group of myasthenics who did best were actually the late onset. It's a little different than a lot of other diseases. Cancers, ALS, I mentioned before, the older you are, the worse you tend to do. MG is a little bit different. It probably has something to do with how your immune system changes as you get older. Some of you may have myasthenia gravis. That would be the green curve. And so the general idea here is that over time, you can get the majority of patients, even the seronegative patients, which are in red here, into this sustained minimal manifestation status category, which is great. The problem is on this x-axis, this could take years. And we don't want it to take years. And I'll get to that in a few slides forward. We'll get to that point on the timing of this. But this is where we stood even before targeted therapy, was around. And so you can see some of the numbers here on the left of the slide. So the median time to get to this minimal manifestation status was about 2.5 years, 30 months. 63% of patients over time did get to this sustained minimal manifestation status category. So not all, but about 2/3. Towards the bottom there in the bullet points, what about death in myasthenia? The death rates in myasthenics reflected their general population of that same age group, basically. So there was really no increase in mortality versus the general population in Austria, at least. So this is instructive, I think. And the next slide is as well. This is a US, not Austria now. This is the Duke database. And Duke has kept close records in this database on myasthenics for a long time. And this is a slightly larger look at patients. This was about 370 patients, as you can see there. None of these patients either, just like the Austrian group, none of these patients got targeted therapy. The treatment goal was minimal manifestation or better. You may ask, what's better than minimal manifestation status? Remission. Remission's better than that. So either remission or minimal manifestation status, it wasn't sustained here. If a patient hit it, they got included here. But anyway, what you can see is, again, the majority over time, but in the bottom, you can see the months. Those are years there. Taking 60 months is 5 years. You all know that. So you can get the majority of patients with conventional therapy into this category, okay? What helped you get to this category? If you were acetylcholine receptor antibody positive, if you had a thymectomy, I was involved with the international thymectomy trial. And just so you know, even patients who had a thymoma did really just as well as patients without the tumor. Obviously, those patients with thymoma always have a thymectomy. If you had a shorter disease duration before you were treated at Duke, you also were more likely to hit this minimal manifestation status or better category. And so you could see some of these data points here. Whether you had a thymectomy or not, it doesn't look like a big difference, but they had a large enough population that if you had a thymectomy, you were somewhat more likely, okay? And more than 80% of patients hit it, but it could take 10 years. That was within 10 years of the first visit. Nobody wants to wait 10 years. Okay, so getting to that, these are the targeted therapies that have been approved so far. There are 6 different columns here. There's actually 7 molecules, but 2 of the molecules are efgartigimod, just slight differences because one has hyaluronidase on it. It's given sub-Q. Anyway, but these are the 6 larger families of this is the 6 sort of distinct molecules that we have, okay, without the second efgartigimod there. And what I did here is collect data to try to compare them. And first of all these drugs do work. They wouldn't have been FDA approved likely if they didn't work, if the trials weren't convincing. But you can see there are some subtle differences here in the time where these different outcomes were actually measured and the percentages. I have a couple things in red here. Let's point out some of those. So an MG-ADL, many of you have filled out an MG-ADL form, either in a study or routinely in practice. And what you can see there is to get at least a 3-point drop. As you descend, as you get to lower scores on the MG-ADL or the QMG, the quantitative MG score, you're doing better the lower your score. So a perfect score on these scales is 0, okay? Anyway, you can see, all right, an MG-ADL of at least 3-point drops was seen in 60% of patients on eculizumab. That was the first drug that we had approved back in 2017. That was at week 26. That's when they checked the outcome. You could go over to zilucoplan. It was 78%, a little bit higher, about 1.5 times the rate of placebo for both of those, okay, getting to that outcome. All right, so you can also look at something like the number needed to treat, to get a single patient, to get a 3-point drop on the MG-ADL. And the lowest one there would be, I think that is rozanolixizumab. But the point here is, yes, the numbers are a little bit different, but there is no huge difference. They're all sort of in the same ballpark, okay, of what we're seeing. Yeah, there's little differences when you look at an individual outcome measure, but in general, we're sort of in the same ballpark. We're all sort of in right field, basically, okay? Maybe not right on top of each other in right field, but in that general area, if I can use a baseball analogy. And then at the bottom here, you can see some quality of life type measures. They weren't statistically significant in all studies. For instance, in the ravulizumab study, the QL15R, was not significantly different between placebo and the active drug, but the active drug looked a little bit better. And some of these others, actually, FGAR, rozanolixizumab, and zilucoplan, there were actually statistically significant p-values looking at the differences in improvement in quality of life on the active drug versus placebo. But I hope this gives you an idea, you know, we're seeing responses for all these agents. Not everybody responds, but the majority of MG patients do respond to these agents. Of course, they come with a cost. These are expensive medications. And so this was a study that Gordon Smith, maybe he's spoken to your group before. He's the chair at Medical College of Virginia Commonwealth University, they call it now, which is in Richmond, of the medical school there. I was the chair until I stepped down a year ago here at University of Buffalo. But anyway, so, you know, we've been friends for a long time, and we compare notes on being chairs as neuromuscular medicine neurologists. But you can see, to get to these different outcomes, it's expensive. It costs a good amount of money, from the hundreds of thousands of dollars to several million to get a patient at that level of an outcome. And so, you know, I wish they were less expensive, but obviously pharmaceutical companies spend a lot of money, hundreds of millions, sometimes $1 billion or so, to get these drugs through the system to get them approved. And obviously they want to recoup their costs. Their stockholders want to see, you know, profits and so forth like that. That's the way it works, fortunately or unfortunately. Okay, so just to keep that in mind. And so with that in mind, also on these new medications, and there's good evidence that they work in older people as well as they do in younger people. This was a slide I got from Dr. Harrer, who may have spoken to you. He's a good friend of mine at University of Vermont. We actually went to the same college, although quite a bit apart. I'm quite a bit older than him. But we've gone to college football games together. We both went to Princeton. Anyway, what he did here is look at minimal manifestation status, that's here, or better for the old drugs, or minimal manifestation status or minimal symptom expression, which is a newer outcome that wasn't really available for the conventional therapies, and just looking at percentages. And, you know, one thing is we may have followed patients longer on the conventional therapies to give them a better chance of getting to these good outcomes, but look at the time frame. This is what I was speaking about before. It can be a long time frame to get to these favorable outcomes with conventional therapy. It can be quite a bit faster. In fact, it is faster for the newer agents, which is an advantage to get people to that good level, okay, quicker. That's obviously an advantageous thing. And so you can see periods of weeks to a few months as opposed to really what can end up being a half a year or longer with the conventional therapies when you actually look at the results for the trial. And so what he pointed out is the actual outcomes look somewhat better with the conventional therapies, at least over time, but the timing, obviously, who won there? These targeted therapies. Okay, so I'm going to stop there. This was the place I was going to stop. We're 15 minutes in, and see if there's any initial questions before I want to show you like 2 more slides on this recent study to really pin down, is it MG or could it be something else, to talk about that. But feel free to ask any questions about the therapies I spoke about the outcomes in the older patients. Oh, one thing I wanted to mention, it wasn't in that Duke study that I just showed you, but another study that they had also confirmed what the Austrians had observed. Later onset patients tend to do better. Okay, shoot away with any questions. I'm going to open up the Q&A because there's 6 of them there, and then I'll look at the chat. It's great about MMS for late onset. How are we doing in avoiding crisis? Okay, So to avoid, thanks for the questions, by the way. So Scott, avoiding crisis in older and young people is kind of the same strategy. What gets people into crisis? Non-compliance with medications, infections. Okay, those are the two biggies. So staying on top of those types of things, making sure patients are taking their medications like they should. Crisis is usually seen in the first 2 to 3 years after an MG diagnosis. This is older data that was published a while ago, but most patients, if they're going to go into crisis, it's early on. After you've had disease 3, especially 5 years, unless somebody gives you the wrong medication or you have a really bad infection, it's unlikely you're going to go into crisis, okay? What is the most that a patient can do to give them the best chance of full remission? So again, compliance with medication. If you get an infection, really talk to your primary care doc or even your neurologist as quickly as you can. Don't let it fester, because if it gets worse, that's more likely to create problems. What else can you do? All right, you can try to impart to your neurologist to be aggressive early on, because the Japanese data clearly shows if you are aggressive earlier on, not just taking Mestinon alone, not even just taking steroids and Mestinon alone. Now I'm talking about generalized myasthenia gravis here, okay? Not pure oculars. But the earlier you are aggressive with generalized MG, and this is also true in multiple sclerosis apparently, the more likely you're gonna have a good outcome, and more likely you're gonna have a good outcome quicker as well. So if there's a way to try to like communicate that to your neurologist, if they aren't being aggressive with therapy and are really not addressing symptoms or signs that you have, you need to communicate that better, okay? Thymectomy, as I showed you, thymectomy is something to really consider, especially we have good data up to about 5 years of disease duration and up to about age 60. Although I can tell you, I just reviewed a paper, hasn't been published yet, so I won't say too much about it, but it was a paper from overseas. They are showing effects, positive effects of thymectomy, even in patients well beyond age 60, okay? Just so you know, okay? So thymectomy is another thing, okay? What ADL score is minimal manifestation status? Excellent question, but there is none. We know what minimal symptom expression is, the MSE abbreviation that you may hear about. It was on one of my slides, on one of Dr. Hare's slides that I showed you. That's by definition an MG-ADL of 0, which is perfect, or 1. You can score only 1 point on any of the 8 items, but only on one of those 8 items can it be a 1. That's minimal symptom expression. If you try to like correlate minimal manifestation status with MG-ADL, it's a scatter. You can see people in minimal manifestation status who have an MG-ADL score, for instance, of 7 or 0, okay? That's true of all these clinical classifications that are defined by the MGFA. There is a range. So we don't have a clear answer on that. It shouldn't be above a 7 or an 8, though, to be honest. An MG-ADL to patients in minimal manifestation status usually won't be above that, okay? But it's not specifically tied to a score like the minimal symptom expression outcome is. Okay, Linda, let me see what you got here. 2 months ago, you're on a self-injectable MG therapy instead of infusions, and there's more questions coming in, so it's jumping around on me. Sorry. All right, sensitive. I would wait. You're having these brief double vision things that are 15 minutes. If it's only an ocular symptom like that, I would probably just wait and just see. I don't think that would merit that short a duration, merit switching that injectable therapy at this point. I would wait and see, okay? Is my best advice that I can give you on that. Now, if it evolves into longer durations of symptoms, or you start having some bulbar, like swallowing, speaking problems, that's a completely different story. Shortness of breath, that's a completely different story, and you may need to change therapy, but not just for the double vision. Double vision is so here and there with myasthenia. If your eye muscle movements are just slightly off, you can have double vision. So I would wait. Okay. Once one gets to MMS, one still has the expense of maintaining it. That is true. It's not, we have to continue to work to keep people in minimal manifestation status. How do we do that? Again, trying to act against other cofactors, medical issues that might arise, especially infections. Being very careful with tapering medication. Don't taper too fast. And that includes both corticosteroids, which I do taper more quickly now because the side effects are bad, but very slow tapering, for instance, of steroid-sparing agents. I only lower those typically every year. Once a year will I allow a dose reduction. How are MMS and MSE different? So again, minimal manifestation status is defined as an MG-ADL score of 0 or 1. Minimal manifestation status is just this language that says the patient is able to do what they want with myasthenia gravis, has no functional limitations. There may be subtle weakness on examination on a careful neuromuscular evaluation. That's how it's defined. Okay. What is considered early treatment? So early aggressive what ages are considered later onset? Good question. Most studies, it's above age 50, onset after age 50, okay? What is considered early treatment? All right, so this is how the Japanese defined it. They, right up front, would do this for patients, okay? Acetylcholinesterase inhibitors, corticosteroids, they use prednisolone there. And then, quickly, often short-term, they had 3 choices: intravenous gamma globulin, IVIG, plasma exchange, or IV solumedrol. So that was their combination of therapies for early aggressive therapy. And then they add tacrolimus usually. It's approved there. It's not approved in the United States. That's a FK506 antagonist, somewhat similar to cyclosporin. Some of you may be on tacrolimus. It also goes by the name Prograf. Anyway, that is part of their general treatment as well. So hitting patients up front with 3 or 4 agents, that's what they do. Okay. And when? Right away. Right away. Patients are seen. Maybe they've come in with 3 months of symptoms because it took 3 months perhaps to get into the Japanese clinic. I really don't know how long their wait times are. Right then and there, they're getting those things going. Okay. More questions. If you are under general control for several years, have you seen orthopedic? Oh, yeah. Yeah. Any kind of stress and a big orthopedic procedure is a stressful situation. They can worsen myasthenia gravis. The other thing, now the anesthesiologist should know this. Obviously, they should know you have myasthenia gravis before the surgery. I do intraoperative monitoring all the time, and so they need to reduce the neuromuscular blockade by 50% or more for those procedures. That's rocuronium, vecuronium, and so forth. Okay. So yes, procedures, a hip replacement's a pretty big procedure. Yeah, they can worsen things. Cardiac surgery, the same. Is there any evidence regarding any of the new medications' ability to have? Oh, yes. Excellent question. Another great question, Scott. Okay. There is real world type outcomes that have been followed in these trials. Just about every one of them. The thymectomy trial was the first one to do it, but the targeted therapy trials did the same. So these agents will reduce your need for rescue therapy, will reduce your need for hospitalizations, will reduce your crisis type episodes prominently, not just like by half, but even more than half. There are bar graphs that show that kind of improvement. And that's always a great thing to tell patients and their families, because that's easier to comprehend for many of us than say, oh, the average MG-ADL score that you'll see, that you'll achieve, the average drop is 3 or 4 points. It's much more meaningful in many ways to say, we will reduce your risk of hospitalizations, rescue therapy, and so forth. Okay, what is the proportion of late onset MG to younger patients? Is MG primarily late onset? So the reason we're seeing more MG cases is almost completely for a higher proportion of patients developing it later in life, especially men. So that's where the growth has been. Now, if you take all numbers, the last I heard on this, It's about 50-50, 50 earlier onset, 50% late onset. Now, I live in a town where young people don't like to be. Buffalo is not kind of one of these favorite cities like Nashville or Austin or Kansas City. And, a lot of young people, they leave. They go to college, they don't want to come back. So most of my patients are older. So I don't reflect that 50-50. I have a college student or two with MG, but not like I did in Dallas. Anyway, so my population looks quite a bit different, but it's about 50-50. Okay. But most of the growth and the prevalence has been in the older side. Okay. Has there ever been a case where the immune system actually stopped producing? Oh, yeah. Oh, we see that. We saw that in the thymectomy trial. You can make people's antibody level 0. But the thing I want to point out, you don't have to make the patient's antibody level 0 to see an improvement. But some patients, their autoantibody, we cannot detect them anymore after treatment. Okay, so it does happen. Yeah, it happened quite a bit in the thymectomy trial. And it's been shown in those studies that have followed it. And even with medical therapy, you can drive an autoantibody level to 0, but that's not a goal. You don't need to do that again to see the improvement. Okay. I'm going to get to this later. As a person age of congenital loss of flexibility, stiffness after exercise. I'll get to that. Let me get back to the slides to answer that one. Okay. So I'll get to that, Richard. All right, let's see what else. Can MMS include regular plex? Oh, yeah. Minimal manifestation status does not restrict which medications you're on or which procedures you're on. That's enveloped in the definition. Now, complete stable remission is the toughest outcome to hit. That requires, by definition, to be off all medications, including pyridostigmine or methadone for a year. That's how it's defined so far. But MMS can envelop. Most patients I have in minimal manifestation status are still on some therapy. They're still taking something. Okay. I'm on Ultomiris and have minimal. It's all these great questions. Okay. That's why I didn't want to show too many slides. I was talking to Allison about this. Okay. I'm on Ultomiris and I have minimal symptoms. I do not lose muscle strength much, but I do have muscle. Oh. Can I do self-harm by, I'm not sure what that word is, aerobic workouts like by doing aerobic workouts? There's actually evidence that mild to moderate exercise is favorable for myasthenia gravis. It's also favorable in many neuromuscular disorders when they've actually looked at it. So you really aren't doing yourself harm, and you actually are probably benefiting your ability for your body to take up oxygen and so forth, cardiac fitness, and all these other things. Especially if you're on corticosteroids, really at any dose, you want to keep moving to sort of counter the deleterious effects steroids have on muscle, which includes causing atrophy of type 2 muscle fibers. And so exercise can help counter those things. So you want to do it. It's good for you. It's good for mental health and so on. You really won't do yourself harm unless you really push too hard. And so my MG patients, when I tell them to exercise, but when they're starting out, these are 3-minute exercise sessions, not 20. And I slowly have them try to build up to 20 or 30 minutes with exercise. Whether it's an elliptical, getting on a bike, swimming is great if you have access to a pool, and simple weights, nothing more than like a 20-pound dumbbell for biceps, no like 50-pounders or even, but some light weights also. Okay. How many years after symptoms start is early? Well, that depends on when the patients come in. Some patients, they lag and don't get seen by a neuromuscular neurologist for a year. But again, the early aggressive treatment is right away, as soon as the neuromuscular neurologist, say in Japan, encounters the patient. I was misdiagnosed for 1.5 years. Am I late treatment? Well, it's always good to get on top of the disease as early as you can, but sometimes it just doesn't happen because of people's journeys to get to the right doctor and so forth. I really wouldn't say that's late treatment. We don't really call something late treatment. We have that early aggressive therapy concept, but not really late treatment concept. Often health plans want you to try only one expensive treatment at a time. How do we get it? Oh, well, first of all, everything is more expensive in the United States, considerably so. What is expensive in early aggressive therapy? The plasma exchange or the IVIG? IV soluble is not expensive. So I imagine they're not getting much pushback from the medical health coverage system in Japan by using one or the other. And to be honest, usually we're not using two expensive therapies at a time. For instance, we're not using two targeted therapies together. In a way, they would counter each other if you know how neonatal FC receptor blockers work. And most of the complement inhibitors, the other class, are IgG monoclonal antibodies. And so you would just flush them out. So it really almost conceptually doesn't make sense to try to use them together. Okay. So, but that's how Japan does it. It's not a considerable expense because they're really only using one or the other of those two expensive treatments, which are either the IVIG or the plasma exchange. By the way, plasma exchange in many countries is quite inexpensive. Quite inexpensive. It's just the way the US system works, it makes plasma exchange fairly pricey. Okay. All right. So I'm going to do 5 more minutes of this, and then we're going to go to the last couple slides. Why does my neurologist dismiss muscle pain and weakness? Had a reverse shoulder surgery with no injury, massive tear. Well, they shouldn't dismiss weakness, especially. Muscle pain itself is not specifically part of myasthenia gravis, although we can see musculoskeletal pain with a couple of the targeted therapies. The neonatal FC receptor blockers can cause some muscle pain. I don't know if you're on one of those or not. Now, if you have weakness, you are somewhat more prone to injuries and so forth because you're working really hard and you're using muscles in a way that they probably weren't designed to be used. And so you can get muscle sprains from that, but it's not specifically a direct cause of the myasthenia gravis, but they shouldn't be ignored. They shouldn't be ignored. All right. And especially the weakness shouldn't be ignored. Unless it's a little eye closure weakness, oftentimes we'll just discard that because it's not really functionally important. Or a touch of, say, neck flexion weakness, but otherwise weakness shouldn't be ignored. Is it useful to check your auto? No, it's really not useful during treatment. There's really not a great correlation of autoantibody levels and treatment response. There isn't. So you can see some people whose autoantibody levels go down and they really don't improve. Most do, but some don't. It really isn't very useful. And so I don't do it. Now, in some trials, they're checking autoantibodies just out of scientific interest, but in routine practice, no. Musk medications, Tacro for 20 years, all new meds for GMG. Okay, yes, Tacro can work very nicely in Musk MG, as can azathioprine and mycophenolate. The big news with Musk MG are the B-cell depleting therapies like rituximab. So if we fail, even after a month with any of the conventional therapies, rituximab is usually our next step. But Tacro can work. I've seen Tacro work in Musk. I've seen it work in acetylcholine receptor autoantibody positive disease too. And it's actually labeled for that in Japan. All new meds are for GMG. That is true. But since Musk was mentioned, 2 of the drugs are approved in Musk MG. Rozanolixizumab and nipocalimab. The 2 newer neonatal FC receptor blockers, it makes no sense as far as we know, and it's not labeled by the FDA either, to use a complement inhibitor in Musk because Musk MG is not related to complement activation. It's primarily IgG4 mediated, and that immunoglobulin antibody class does not fix complement. Okay, I hope I answered all those. And yes, all new meds are for GMG. We don't have any of these drugs approved for ocular MG, but there are trials going on. For instance, there's an efgartigimod trial on ocular MG going on right now. Is it likely to develop constant as you grow? Well, look, we all, as we age, things do deteriorate. Our heart can't beat as fast when you exercise. Our lung function does decline. If you look at normal values on a pulmonary function test, they do decline as you get older. But you really, unless you have an underlying disease state, you really shouldn't feel shortness of breath at rest or doing, mild exertion. Obviously, when you exercise, you get short of breath. So if even in an older person, that suggests there's something going on. What could it be? CHF, congestive heart failure, or other types of cardiac disease. If you've been a smoker, if you have asthma, If you have chronic pulmonary disease, there's so many different things that could potentially do that with breathing, or it could be myasthenia gravis. And that's the jobs of the doctors to try to figure out. I assume you have myasthenia and you turned 51 and you're feeling short of breath. If you have a good chest x-ray or chest CT, you've seen a pulmonologist and they can't find anything, I would wonder perhaps maybe it is MG related, and perhaps your medications can be tweaked a little bit to see if it gets better. The other thing is, when you do pulmonary function tests, it gives you an idea if it's neuromuscular related or not, based on whether it's an obstructive or restrictive pattern. It's not 100% predictive, but it can give people ideas. I don't know if you've had that done. Can menopause cause a flare-up? Have I seen menopause cause a flare-up of MG? Pregnancy, rarely. Usually women who are pregnant do fine or even do better with their MG. But right after they deliver, there's a little bit of an increased risk of flaring right after delivery. Menopause. Obviously, estrogen, progesterone levels are going down. I really have not heard of menopause. There may be a series on that. I'm just not aware of it, if menopause can worsen it. Ooh. All right, let's see. It's 8:05 for me, 7:05 for most of you, because I think most of your central time. Can I show you a couple slides that really address what the question was? Let me go ahead and do that. I knew there would be tons of questions, but all right, let me try to keep where we are. And I just want to go over this because it actually addresses a couple of things that were asked. Okay, so this was a study just earlier this year. It was an Italy-based study over a 20-year period, and they looked at false acetylcholine receptor antibody positive results, because it happens, okay? And they used a RIPA, which is a radioimmunoprecipitation assay. That's what RIPA stands for, which is the standard assay that we mostly do in most countries to check for acetylcholine receptor antibodies and the other antibodies in MG. This was 5 to 91-year-old patients, so quite a few older patients in here, okay? Of all these patients that they looked at, there were 362, 50 of them, from the best clinical evaluation they could do, 50 of them didn't have myasthenia gravis. Okay, and we'll get to what they had instead on the next slide, okay? But in general, non-MG patients were younger. So the older group, and we were talking about its age or so forth, the older group was more likely to actually have myasthenia gravis, okay? All right, I have to just shrink this so I can see all my text, okay? Also, the non-MG patients were somewhat more likely to be female than male. So an older male, if their antibodies were positive, it was almost certain that they had myasthenia gravis. But if they were women or if they were younger, it was somewhat less likely. Okay. The non-MG patients had somewhat lower receptor antibody titers. So here the level does matter. It doesn't matter following treatment response, but it matters in the diagnosis. So those patients who were deemed not to have myasthenia gravis, they had a lower titer than the first one on a second draw, or they were completely negative on the second draw. You have to realize assays differ from lab to lab. So if people aren't sure whether it's myasthenia gravis, even if you have a positive antibody, it's best to get it repeated to see. And finally, they found this sort of basement requirement of at least 1 nanomole per liter. That's how we measure binding antibodies. At least 1 nanomole per liter more reliably identified actual myasthenia gravis. And you can see that was excellent specificity and a positive predictive value. That's what PPV stands for. It was almost 100% for both, 97% and so forth, 99.8. That's really, really good. And so that was a lesson to be learned, that when antibody levels are below 1, they're not quite that 1 nanomole per liter, they're lower, say 0.7, and there is something else fishy going on that just doesn't really match for MG, that's more likely to be a false positive, okay? All right. And they also made a point, there's a lot of autoantibody testing for myasthenia gravis in the United States. People come in with chronic fatigue, fibromyalgia type symptoms, long COVID type symptoms, and they get tested for autoantibodies. And the problem with that is the way the titers are set and lab abnormalities are set, if you test 20 or 30 people who are completely normal, indiscriminately just test them, one in those 20 to 30 people is going to have an abnormal antibody level, even though they don't have the disease that's associated with that autoantibody. I hope that's clear. So there's always this risk of false positives. And if you just, gunshot, scattershot testing across the board, you're going to get into that situation more likely. So the testing really should be done in the appropriate clinical setting. Okay, and so on the next slide, let's see. On the next slide is the alternate diagnoses in these folks, in these 50 or so patients who did not have MG. And I have certain arrows that you can see there pointing to the left, because these are either pertinent to know about or especially pertinent as you get older. So asthenia, this kind of like just sense of, tiredness, fatigue, lack of energy, lack of strength, that happens as you get older. So that accounted for a few patients. Parkinsonism explains some of the patients. So somebody mentioned stiffness and so forth. Does that happen more in MG? Well, we all get stiffer as we get older, as far as when you first get up in the morning. But these are patients that actually had Parkinsonian features and had been misdiagnosed with myasthenia gravis. And the reason I have the arrow there is Parkinsonism is certainly more common as you get older. Parkinson's disease usually affects people, say, above age 50 or 55. Michael J. Fox, that is an exception to get it that early, okay? That is way off on the left side of the scale to get Parkinson's disease. I think he was in his late 20s when he first had symptoms. Functional neurological disorder, just pointing that out. These are patients who don't have an underlying neurologic issue at all. It's a psychiatric mental health issue. And some of the patients were deemed to have that as opposed to actual myasthenia gravis. And then there's a whole category of others, and things that would fall in there were like chronic fatigue syndrome or post-infectious fatigue, which happens after a lot of viral infections, can after bacterial infections too. Fibromyalgia and things like that fell into what actually was the largest category, but that was a mishmash. So they just put it all together. So realize these things can happen. I just noticed rheumatic diseases at the top there. Yes, rheumatic disease tends to occur more as you get older. That's, disease of your joints, rheumatic problems. So anyway, these things can occur as masquerades for myasthenia gravis. And always be cautious if those autoantibody levels are too low. And so how can we figure out, is this aging or is it MG? The fatigue pattern should have a clear element of worsening with exertion and some recovery with rest. Rest, by the way, was the first treatment we ever had for myasthenia gravis before we had any of these medications. So you should be able to tease out some kind of pattern where fatigue worsens with exertion. If people just feel fatigued all the time, that's probably going to be something else. What could that be? Major depression, other mental health issues, chronic fatigue syndrome, those types of things. All right, so that can help. There shouldn't be any monocular diplopia. What does that mean? We see consults frequently for patients who have double vision with one eye open, the other eye's closed. That doesn't happen in myasthenia gravis. That's an ocular problem. And if you look on the prior slide again, you see ocular diseases right under the rheumatic, that second row there, that accounted for a lot of these non-MG diagnoses, okay? So myasthenia gravis, the double vision is only present when both eyes are open, okay? If not, it's an ocular disease problem, usually in the eyeball itself. Asymmetry in ocular symptoms and signs, you should see asymmetry. Usually it's not completely the same from one eye to the next. If you see asymmetry, more likely to be MG. If you see everything symmetrical, it's more likely to be something else, oculopharyngeal muscular dystrophy, for instance, or senile ptosis that's affecting both eyelids, where your muscles just lose their elasticity and their contractility and so forth, and people's eyelids droop a little bit, some people as they get older. Hence why there's plastic surgery for people who want to look better, I suppose. Okay, true cranial, truncal, and proximal weakness. When you push on the muscles, a good neuromuscular neurologist, we can tell, I think, better than most other classes of neurologists, whether there's actual real weakness there or if it's sort of functional, the patient's doing what we call giveaway weakness, and so forth. There should be true weakness that you can pick up on exam in a myasthenia gravis patient who is not controlled, okay? And then we have all these laboratory tests, and many of you have undergone these things. We have the ice pack. We don't have edrophonium testing easily. That's tensilon testing, but the ice pack, you can always get some ice in a bag and stick it over a droopy eyelid, and you should see a response to that in many patients. Then we have the electrophysiology, the awful shock test, the single fiber EMG, the awful needle test. You want to have good baselines. You want to go to a lab that knows how to do these. And you need to have good waveforms, reliable waveforms, because an overdiagnosis of MG is often based on a poor RNS, repetitive nerve stimulation. That's what that stands for. SFEMG is single fiber EMG. Serologic testing with the attention to the titer. As I mentioned before, again, the nanomoles per liter should really, if it's below 1 and you're not certain. Now, some MG patients really do have autoantibody titers that are that low, but if there's something you're not sure about and it's a low titer, repeat the blood test, as I mentioned. And there's also percentages for modulating and blocking antibodies, and people often get into trouble with that because the normals are often 20% or less, and they'll make a diagnosis based on a 22% value. Those percentages in real myasthenia gravis are usually way high, 70%, 80%, and so forth. And then a response to therapy. So if you see a patient who comes in and they haven't responded to 3 or 4 attempts of therapy for myasthenia gravis, given an appropriate dose, you really need to doubt the diagnosis. And that may just be aging or something else as opposed to MG, because just about everything we throw at people that's immunologic, it's going to improve 70 to 80% of the patients over time. And so if it's one after another that hasn't helped, your chances, you can actually do the math. You know, a failure of one agent, yeah, that can happen 20 to 30% of the time. But 2 agents, it's simple math. You multiply 0.2 times 0.2 or 0.3 times 0.3. You're talking about now 4 to 9% of patients with MG are going to fail 2 drugs. Not a lot. And if you keep adding more drugs to that, those percentages get even lower than 4 to 9% chance. So just keep all that in mind. And those are all the slides I want to show. And now I'm going to go back to the questions. Okay, so let me get down here where we were. I don't want to miss them. Okay, as a person ages, can GMG manifest as loss? Okay, I think I tried to answer that. Manifest as loss of flexibility and stiffness. Again, it shouldn't just be loss of flexibility and stiffness. There should be other clinical features that I kind of mentioned just a moment ago when I was going over the slides. I do think that MG patients probably are more, probably have more stiffness in the morning. You know, even subtle weakness can just make it more difficult and feel, you know, somewhat stiff and so forth. Always keep that Parkinson issue in mind because some patients were misdiagnosed and had Parkinson's instead of MG. Okay, age 83, 2 years on Mestinon and Pred, double vision improved, but MGL still, yeah. So your MG-ADL is still 7 to 8. So, you know, we don't really treat MG-ADLs specifically, although it helps us guide treatment in the context of examinations and symptoms and getting your history. But if you're unhappy with certain things beyond the double vision, it sounds like there's other issues besides double vision, you could do better. There's no restriction to using other drugs really at age 83. There's a lot of different options you potentially could try. From a steroid-sparing agent, which doesn't work real quickly, or a targeted therapy. Realize most of these trials required an MG-ADL score of at least 6 to get in, and you're in that range, and so it could be improved. But you have to like discuss the cost benefit of doing that. You know, there's always risks with any therapy, but you could expect to do better than an MG-ADL 7 or 8. I'm not personally happy when my patients come in with an MG-ADL of 7 or 8. Most of my patients have MG-ADL scores of 3 or less. Many have them at 0 or 1. So, you know, when I recently had a patient at 7 or 8, what did I do? we tried something else before. This was a patient actually was in a study. We're trying nipocalimab in that patient. Okay, just as an example. Is there anything that I can do to build up my immune system and not push? I'm not sure what that means. And not push my AChR antibodies into overtime. Oh, you mean like if you boost your immune system, will you also at the same time increase your receptor antibodies? That really doesn't happen. You really shouldn't be concerned about that, that it's going to worsen your disease, because you're going to be potentially helping so many other aspects of your immune system that will counter any impact that even a slight increase in acetylcholine receptor autoantibodies would have. That's not really something that we think about or worry about. Okay. How can you build up your immune system? I mean, a good, a good diet, not too many carbs, not too many sweets, eating fruits and vegetables, things like that. Just following those kinds of good habits. I know there's supplements that supposedly can boost your immune system, but you really shouldn't think that using those kinds of things is going to worsen your myasthenia gravis. Yeah. Don't take magnesium, by the way. Don't use magnesium if you're going to take supplements. All right. Is there anything in the pipeline? Oh, yeah, for seronegative. There's a couple of studies in seronegative MG right now. And so hopefully we'll have the results. Realize in the trials, there was a suggestion. It wasn't great. There were some seronegatives in the trials. And there's also been some case series now of seronegatives that suggest that, for instance, FcRn blockers and neonatal Fc receptor blockers work in seronegative myasthenia gravis. Okay, which is not surprising to me, because over time we have found that most things that work in acetylcholine receptor autoantibody MG also work in seronegatives. Okay, so yes, there are things in the pipeline, and hopefully we'll get an approval for seronegative MG, so we won't have to fight in getting approvals. Okay, from insurers. Forgive me if this question is a bit niche or specific to women going through perimenopause or menopause. How does HRT impact the symptoms? I just don't know that literature specifically. HRT is usually estrogen. From pregnancy, where there's big increases, I'm just thinking through this in my mind. Progesterone goes up. I think estrogen does too. I don't think there's any clear evidence, just going through it, of estrogen worsening myasthenia gravis, okay? Of hormone replacement therapy, of it worsening myasthenia gravis. I noticed that my symptoms really ramped up during hormonal changes. I'm partly, I'm going to have to search on that, or maybe have your neurologist look at that, because again, I don't know that literature that well, or how well it's been studied. But I can just tell you, I don't think my colleagues or I have really had issues with HRT worsening myasthenia gravis, or perhaps even helping myasthenia gravis. Obviously, in neurology, there are certain diseases that are impacted by the female hormones, estrogen, and so forth. Migraines, for instance, which really seems to be big time changes in the levels of female hormones, can trigger a migraine. They've also been linked to thrombotic events like stroke, deep venous thrombosis, and stuff. All right. How do you tease out the deficits that old age brings from residuals? That's so hard. It can be really hard. But again, looking at the exam, sometimes, not often, but sometimes we'll repeat repetitive nerve stimulation or even single fiber EMG studies and compare the numbers to where they were before to see if there's a suggestion of worsening if you're not sure. Another thing that I'll point out, if things aren't working right, as far as the myasthenia gravis behaving like we think it should in response to medications, I'll repeat a chest CT to make sure a patient hasn't gotten the thymoma. Now, you've all had chest CTs when you were diagnosed or shortly after you were diagnosed. Hopefully not more than a week or two. You should get it done pretty quick. But sometimes people don't have a thymoma initially, and it only bruised later. And so that would be something to look at. In that kind of scenario, if there's really clear clinical evidence that it's a worsening of MG. Now, look, I'm not as old as some of you, but I am in my 60s, and I hike seriously hiking on the Appalachian Trail. And I can tell, I started about 10 years ago on section hikes. There's a difference. I cannot do now what I did 7 or 8 years ago on the trail. I just can't. I wish I could because I'm trying to finish it. But you get older and just things do deteriorate. Your stamina, and I know a lot of you are going, God, Appalachian is not even something I'd ever imagined doing. But just trying to put that into context, we do slow down our heart rate. Your heart rate max when you're already, by the time you're in your 60s, no matter how hard you push it, it's hard to get it above 130, 135. I noticed that. And so, your ability to really push harder is somewhat limited by your cardiovascular status. That's just a normal part of aging. And our muscle mass does go down. It does as you get older. All right. My nurse says I've lost about 50 my muscle mass over 10 years. I'm still rather weak and restricted on what I can physically do. Unbalanced issue. Well, that sounds worse than just aging, to be honest. And if it's, I don't know how much steroids you've been on. If you've been on consistent steroids, I really would try to get off because steroids long term are just not good for muscle mass. They just aren't. I don't know about the balance issues. I'm wondering if there's something else going on, and I don't know how old you are. Balance gets worse as we get older. For instance, once you're above 70, your ability to perceive vibration in your toes is diminished. That's part of your large fiber sensory function. It goes down in normals who are aging. And so your balance is impacted by that. Our vestibular system doesn't work as well as we get older. I don't know if any of you have tried to go on I used to love going on roller coasters. I cannot tolerate going on a roller coaster more than once anymore. It just messes me up. My vestibular system doesn't adapt to it as well anymore. So that can all be part of this, or you could have cervical stenosis, or you could have peripheral neuropathy or something that's causing the balance issues. As far as the breathing, it could be partly the MG. It could be partly some of the muscle mass loss. Yeah, yeah. But yes, 70, I would be worried that there's actually something else medically going on beyond MG there. Is just the picture I'm getting. Is it possible for MG to be, Kathleen, is it possible for MG to be developing for a long while before? Oh, yeah. So we know that patients who develop MG, they've likely had acetylcholine receptor autoantibodies for a while. How long, we don't know in everybody, but they can have been present for a while. So the pathophysiologic setup is there. That doesn't mean we're going to start checking normals for autoantibodies, but yeah, it could be developing for a while before you develop symptoms. And look at a thymoma. Thymomas generally aren't tiny when we first pick them up. They're not just like half a centimeter by half a centimeter. They're usually fairly large. And so at least from thymoma-driven MG, that thymoma has been growing for quite a while. All right. Is giveaway weakness always discounted? I try hard, then can't push against force, and it is noted as giveaway. Yeah, so you'll see the doctors do that. We're not perfect at determining if it's giveaway, but there's certain clues that we can use on exam, and certain ways to try to negate it. Like I always, when I'm facing that and I'm not sure, I do a 1, 2, 3 count and have the patient push as hard as they can for a second. Some of the giveaway, if it's not all of a sudden, can just be fatigue over time that could be MG related. Is it always discounted? Well, I would say it's mostly discounted by neurologists. We're generally the only doctors who really kind of classify giveaway weakness because other types of medical personnel aren't really good at assessing strength like we are. But I would unfortunately say most of the time, if it's noticed, it is somewhat discounted. Yeah. Usually people can exert a good contractile force for a second or two. So that 1, 2, 3 thing, if the doctor's asking you to do that, really try hard as much as you can. Because then if you really do develop more fixed weakness, they'll not discount it as much. But that's a tough question. That's a tough issue, Laura. All right. is in the theme of MG versus aging. Lots of talk about the bladder and bladder. All right. Yeah, I was on sabbatical overseas. I was actually in the Middle East last year. No, not last year, this year. And we did one of the research projects I was involved with was on urinary dysfunction. Yes, urinary dysfunction does occur more likely in MG. It is not something that's well understood or even well documented. But it can be seen. We did see about a twofold increase in urinary dysfunction in myasthenics versus a control population of the same age. Why is it happening? Well, the bladder is smooth muscle, but the things supporting the bladder are not. They're skeletal muscle. And so if those are impacted by MG, which impacts skeletal muscle, it may change the anatomy and conformation of the bladder and how it's related to the ureters and so forth, that actually end up releasing the urine into the urethra in both men and women. So that was one thought that we had. We also had a thought that maybe some of the medications that we use could be impacting the overall urinary dysfunction as well, because acetylcholinesterase inhibitors, for instance, can increase autonomic activity, which can lead to stress, incontinence, urgency, and things like that. So yes, you can see some things that are urine. This was, by the way, more on the urinary side than on the stool side, okay? Than on things like on bowel function. It was more on the urinary side, just so you know. How to deal with that? Not easy. Not easy to deal with. Yeah.
Dr. Wolfe, I know it is 7:30.
Oh my God.
And
yes.
We don't want to take up more of your time. I know you probably had a long day. So you can either
I started at 7:30 this morning. So I'm on my 15th hour. I just started 7:30 tomorrow morning too. Is B12 great for MG? I'll just answer that. Well, if you're B12 deficient, it's good for MG. If you're not, it's not going to help, I don't think. All right. Oh, I answered a lot of questions, I thought.
Oh my gosh. You knocked it out of the park with all the Q&A. We can't thank you enough. And it's such an important topic. And we know a lot of people want to talk about it in the community. So we really
I can give out my email address. First of all, it's in the public domain. You can find me because I'm in the State University of New York system, and we're required to have our email in the public domain. So anyway, by New York State rules, my email is gilwolfe at buffalo.edu. At buffalo.edu is easy. Everybody knows how to spell Buffalo, I hope. gilwolfe before the @ sign. If you have a pressing question, hopefully you won't flood me with them, but if you have a pressing question, feel free to email me. Just please let me wait till tomorrow or Wednesday to try to answer them, okay? All right.
Thank you a million times over. This was fantastic. We really appreciate you taking time after your long day to meet with our virtual attendees. So
I'll just answer one more real quick. The rheumatoid factor and GMG. Just so you know, myasthenia gravis is associated with other autoimmune diseases, so you can see rheumatoid arthritis in MG, just like we can see lupus or thyroid eye disease in MG. MG itself does not lead to elevated rheumatoid factor, but if you have a crossover issue in another organ system, yes, you can see a positive rheumatoid factor. The most common things that we see are thyroid abnormalities, and lupus, I would say, is more common in MG than rheumatoid arthritis, but I may be wrong on that. But at least that's been my experience. Okay. All right.
Thank
guys.
You. Thank you. We hope everyone has a happy Thanksgiving, and we'll see you all in 2026.
Thanks, Allison.
All right. Good night.
Thanks, everybody, for the great questions. All right.
Thank you.
All right.